Welcome to part 2 of vasculitis. You're in for a treat because we've saved the smallest vessels for last, but they're definitely not least. Small vessel vasculitis, small as in affecting the arterioles, capillaries, and venules, is actually the most common of all the vasculitides. We'll break them down by pathogenesis for simplicity. First, the type 3 hypersensitivity diseases Henoch-Schönlein purpura and cryoglobulinemia. Next, we'll tackle the ANCA-positive diseases, microscopic polyangiitis, and Churg-Strauss syndrome. Finally, we'll wrap it all up with anti-GBM vasculitis, also known as Goodpasture syndrome, which should be familiar to you if you've already checked out our glomerulopathy sketch. And if you haven't, well, that's on you, isn't it? Welcome to Goodpasture Golf Course. No. This isn't one of those hoity-toity country clubs with bag jockeys and knickerbockers and running water of... We like to keep it laid back, you know? Just take a look for yourself. Nice shot, Braden. Yep, another happy member out on the green, breaking his club in sheer joy, I bet. Hold on. Hey, remind me to discuss the dress code with you later, Braden. Nah, nothing serious. Just make sure those socks are within 1 to 2 inches of the midpoint between the knee crease and the crest of the calf, okay, champ? All right. Before we get into the nitty-gritty, let's go through some of the common features of the small vessel vasculitides as a group. By small vessel, we mean small arteries, arterioles, capillaries, and venules. In other words, don't expect the aorta or its branches to suffer much damage this time. Instead, think about the major networks of small vessels in the body. Take the skin, for example, where damage to small vessels and capillaries manifests as petechiae, nodules, bullae, all kinds of stuff. The classic cutaneous manifestation of small vessel vasculitis is palpable purpura, represented by the red polka dots on Braden's gaudy golf attire. These lesions consist of erythematous papules and plaques, usually around a centimeter or less in diameter, though they can coalesce to cover a larger area. Also, as his caddy holds him back while he recovers from his tantrum, remember that these purpura are characteristically palpable and non-blanchable, which means they're raised and don't change in color when you press on them. The next small vessel system you need to worry about is inside the kidney, all those fragile little glomeruli. Glomerulonephritis is a part of pretty much every small vessel vasculitis syndrome, symbolized, as usual, by that glomerular bendy straw. Mild glomerulonephritis can show up as hematuria, proteinuria, and azotemia on labs. Watch out, though, because this isn't just some amateur with a fancy golf bag cup holder. All the vasculitis syndromes covered in this sketch can cause a rapidly progressive glomerulonephritis, or RPGN, which results in a precipitous loss of renal function, characterized morphologically by crescent formation within the glomerulus, hence the crescent logo we've added to his gear. I mean, it's no Nike, but a sponsor's a sponsor, right? Check out our nephritic wall of China sketch for a more in-depth discussion on the pathophysiology of glomerulonephritis. The last small vessel system I want you to think about is in the lungs. Many small vessel vasculitis syndromes also cause pneumonitis, which can present as infiltrates, asthma, interstitial fibrosis, and even alveolar hemorrhage. We'll highlight the important pulmonary signs and symptoms throughout this sketch. All right, before we get into the specific pathologies, we have to talk about ANCA, also known as anti-neutrophilic cytoplasmic antibodies. ANCAs are autoantibodies formed against antigens found in, yeah, you guessed it, neutrophils. Because neutrophils are kind of like the first responders of the immune system, neutrophils are symbolized by our recurring neutro first responder EMTs. There are 2 types of ANCA antibodies that are commonly seen, C-ANCA and P-ANCA. C-ANCA, also called anti-proteinase 3, or even PR3-ANCA, is an antibody directed against proteinase 3, an enzyme found in the cytoplasmic granules of neutrophils. And that's what the C in C-ANCA stands for. And that's why on our first stretcher, we've placed the antibody golf tees inside the clumps of sand granules that have accumulated on the surface. The PAR3 sign is there to remind you that we're targeting proteinase 3 specifically, and also because it's a PAR3. P-ANCA, on the other hand, also called anti-myeloperoxidase, and sometimes even MPO-ANCA, is an antibody directed against myeloperoxidase in the perinuclear lysosomes in neutrophils. That's P for perinuclear. kind of like how the antibody golf tees are lined up along the periphery of his midsection. An unusual but no less unfortunate accident. The myeloperoxidase wash is there not only to thoroughly sterilize that penetrating abdominal wound, but also to remind you that we're targeting myeloperoxidase specifically. Okay, everything makes sense so far. Or, actually, no it doesn't. If these antigens are inside neutrophils, how did these ANCA antibodies bind them and cause damage in the first place? Well, we don't really have a good answer for that. There's not even a good answer for why these autoantibodies form in the first place. It could be after a viral infection, a reaction to drugs or toxins, and a genetic predisposition may come into play as well. In any case, the neutrophils of sensitized individuals start to express PR3 or MPO on the cell surface, not just inside the cell. What? This allows C-ANCA or P-ANCA autoantibodies to directly bind and activate neutrophils. Neutrophils probably also upregulate their expression of surface Fc receptors as well. Once these ANCAs bind, neutrophils get way too excited, leading to all kinds of cytokine release, reactive oxygen species generation, and endothelial damage. So say hello to vasculitis. Since ANCAs are directed against the neutrophils themselves, they tend to not form large immune complexes, meaning a biopsy of affected tissues usually doesn't show much immune complex deposition on staining. This is called a pauciimmune hypersensitivity reaction. Okay, now that we've covered ANCA, let's move on to our first small vessel vasculitis, Wegener's granulomatosis, or at least what used to be called Wegener's. It's now referred to as granulomatosis with polyangiitis, or GPA for short. We're going to stick with the German on this one, though. Bring over the Wegener sandwich. Apt choice of club, sir. This condition is most commonly seen in older adults. It's thought that exposure to some kind of mysterious airborne infectious or environmental antigen, like this plume of sand here, leads to the development of anti-neutrophil cytoplasmic antibodies in genetically susceptible individuals. In fact, up to 90% of these patients are ANCA positive, predominantly the C-ANCA variety, which is why we've placed this whole sand trap scene next to the cytoplasmic ANCA EMTs specifically. A small subset of patients, however, especially those with more limited disease, have no ANCA at all. So regardless of ANCA status, for a definitive diagnosis, you have to look at histology. Granulomatosis with polyangiitis is a systemic necrotizing vasculitis. In other words, besides an infiltrate of inflammatory cells, on histology, you'll see granulomas and tissue necrosis. Granulomas, remember, are like a mosh pit of angry activated macrophages. And at Sketchy, they're symbolized by an accumulation of macro cages. And necrosis? It's highlighted by that ominous necrotic skull. Whoa there, Jane Blalock! Don't touch it! Gotta play the ball as it lies. We'll get back to that necrotizing granulomatous inflammation in a second. First, in the setting of a systemic vasculitis syndrome, expect some of those classic constitutional symptoms, including fatigue, fever, weight loss, arthralgias, as well as labs that reflect an inflammatory syndrome, including ESR and CRP, all discussed in our last scene. All right, take a close look at his luxurious and form-fitting golfing shorts. The triangle pattern is there to remind you of the classic triad of clinical findings associated with GPA: upper respiratory symptoms, pulmonary symptoms, and glomerulonephritis. Think nose, lungs, and kidneys.
Ow, my nose.
Let's start up top, where GPA takes the form of a chronic rhinosinusitis. Patients often present with nasal congestion and purulent nasal discharge, kind of like a really bad sinus infection that won't go away. The ensuing necrotizing granulomatous inflammation causes mucosal ulcerations and bleeding in the nose and throat. And as that ball smacks him right on that nose bridge, remember that this inflammation gets destructive. Septal perforation can occur, for example, classically manifesting as a visible saddle nose deformity. Additionally, inflammation often extends down into the trachea and bronchi, where ulcerations and scarring can cause stenosis. Next in the triad are the lungs, where GPA inflammation results in the formation of yellowish hemorrhagic nodules. Central necrosis may also be present, resulting in cavity formation. This is illustrated in the sand trap below, all those clumps and divots symbolizing nodules and cavities in the lung parenchyma, usually a few centimeters in size. Pulmonary symptoms include recurrent pneumonitis or pneumonia, an interstitial fibrosing lung disease, or even a life-threatening alveolar hemorrhage, causing rapid onset dyspnea and hemoptysis. And remember who's sponsoring this whole event. Last in the triad is renal disease, which can range from mild hematuria or proteinuria all the way to rapidly progressive glomerulonephritis and renal failure. Diagnosis of GPA can be made with positive C-ANCA testing combined with biopsy of affected tissues. Often, granulomas coalesce and are visible on X-ray as densities or radiolucent cavities. Fortunately, mortality associated with GPA has plummeted with the use of modern immunosuppressive therapy, with steroids and cyclophosphamide, along with other immunosuppressants as needed. The 5-year survival rate is now over 80%. All right, let's move on to our next small vessel vasculitis. Microscopic polyangiitis, more like tiny microscopic polyangiitis. The microscopic part of microscopic polyangiitis means that we're hitting mostly small vessels here: arterioles, venules, and capillaries. This condition, in fact, takes over the microvasculature pretty much everywhere, including the skin, kidneys, lungs, GI tract, and peripheral nervous system. The exact cause of microscopic polyangiitis is unknown, but one major player here seems to be inflammation mediated by those anti-neutrophil cytoplasmic antibodies we keep talking about, which are detected in the circulation in about 90% of patients. Notice that we're orienting this next scene next to the P-ANCA EMTs, with those antibody golf tees attaching to the periphery of the nucleus, rather than the cytoplasmic granules. That's because a majority of cases are associated with P-ANCA specifically. A large proportion of patients, however, are either C-ANCA positive or have no ANCA at all. So the mechanism at work here isn't fully understood, but P-ANCA is the one to remember. Let's talk about clinical presentation. In addition to systemic inflammatory symptoms such as fever and weight loss, as well as the palpable purpura we described at the beginning of the sketch, microscopic polyangiitis likes to hit the lungs, as highlighted by those red sleeves sitting in front of his chest. The presentation can be pretty similar to Wegener's, in fact. Minus those nasty pulmonary nodules and cavities. Pulmonary symptoms include recurrent pneumonitis, pneumonia, or even an interstitial fibrosing lung disease. And as he spits out those unnaturally aggressive fire ants, keep in mind that a life-threatening alveolar hemorrhage can occur, causing rapid onset dyspnea and hemoptysis. How about another word from our sponsors? Microscopic polyangiitis also likes to hit the kidneys. Well, the glomeruli, actually. Glomerulonephritis can lead to hematuria, proteinuria, and azotemia on labs. While usually mild, watch out. Remember that all these conditions can progress to a rapidly progressive glomerulonephritis. When there's renal involvement, a kidney biopsy will likely show inflammation, but few or no immune deposits in the glomeruli, a so-called posse-immune pattern that's common to the ANCA-positive vasculitides. This includes Wegener's and our next ANCA vasculitis, Churg-Strauss. So instead of the usual quiet sign held by course officials, we've got a posse sign. Shh, no immune complexes, please. Churg-Strauss syndrome, known as eosinophilic granulomatosis with polyangiitis, in contrast to regular granulomatosis with polyangiitis, which was Wegener's, remember, is a rare small vessel vasculitis with one important distinguishing feature: eosinophilia. Churg-Strauss features an eosinophilic phase that includes peripheral blood eosinophilia as well as eosinophilic infiltration of multiple organs, such as the lung and GI tract. In this scene, eosinophils are represented by the pink granular golf balls. And as they spill out onto the fairway, let it remind you of these eosinophilic granular immune cells that can be found in both the tissues and out in the blood. Why all this is happening? We don't really know. It's thought that some kind of environmental factor, such as an allergen, infection, or a drug, triggers an abnormal and hyperactive immune response in genetically predisposed individuals. What results is an interesting allergic phase that really puts the churg in Churg-Strauss. This prodromal phase consists of the usual atopic disease stuff, like eczema, allergic rhinitis, nasal polyps, and recurrent sinusitis. Asthma is the cardinal feature here. In fact, asthma is present in virtually every patient with Churg-Strauss. Some even undergo long-term treatment with glucocorticoids for years, merely to control their asthma symptoms. And it's not until the glucocorticoids are reduced or stopped that the vasculitic phase of the disease becomes apparent. In many patients, an eosinophilic infiltration takes over the lung parenchyma, leading to pulmonary opacities, pulmonary nodules, and pleural effusion. On histology, the lungs are rife with eosinophils, tissue necrosis, and granulomatous inflammation, complete with those multinucleated giant cells that signify granuloma formation. In about 30 to 50% of patients, eosinophils also invade the myocardium and surrounding tissues, which can lead to myocarditis and congestive heart failure. This is actually a major cause of poor prognosis and early death in these patients. The third phase of disease involves a small vessel vasculitis. About 40 to 60% of patients are ANCA positive, though it's not clear how big of a role ANCA plays here. Since perinuclear ANCA is the type that usually predominates, we've placed this trigger right next to those p-ANCA EMTs. Expect the typical constitutional symptoms that go along with pretty much every vasculitis syndrome, such as fever, weight loss, and fatigue. Skin changes include palpable purpura, nodule formation, and ulceration. And as we've seen with the other small vessel vasculitides, the kidneys aren't safe. While not as prominent a feature as in Wegener's and microscopic polyangiitis, glomerulonephritis can present with anything from microscopic hematuria and proteinuria to a rapidly progressive glomerulonephritis, with crescents and everything. Spread of vessel inflammation to the surrounding tissues can lead to neurologic symptoms, such as paresthesias or paresis. In fact, peripheral nerve involvement can be seen in all of the ANCA-associated vasculitides. So let's put some frayed wires inside the ANCA golf cart. The characteristic pattern of neurologic involvement is known as mononeuritis multiplex, which requires damage to at least 2 different nerves located in different parts of the body, such as foot drop from tibial nerve damage combined with wrist drop from radial nerve damage. All right, that's it for ANCA. And you know what? Instead of moving on to the next small vessel vasculitis, how about a complimentary shoe shine? A Henoch-Schönlein shoe shine, that is. Yeah? Hey kid, you heard the man. Now wipe. Sorry about that. He's new. Henoch-Schönlein purpura, or HSP, is a type 3 hypersensitivity-mediated vasculitis most commonly seen in young children, with peak incidence around ages 6 to 7. Little known fact, we've actually got a whole underground network of young children working at the country club. We call it an internship opportunity, if you will. You should really check out the clubhouse later. You'd think we were running some kind of unsanctioned child labor ring in there if it weren't for all the golfing patrons around. Don't look into that. Hey, here's an interesting fact. Most cases of HSP present in the spring and fall, with almost none seen in the summer. The seasonal nature of HSP is thought to be linked to the seasonal pattern of upper respiratory infections, as somewhere between 1/3 and 2/3 of cases develop after a URI, such as the flu or a strep pneumo infection. It's not entirely clear what's going on, but it might have something to do with defective mucosal immunity. Antigens are allowed to sneak in and get picked up by antigen-presenting cells, which proceed to call the rest of the immune system over. The key player here is IgA. Lots of IgA. IgA binds to antigens, IgA binds to IgG molecules, IgA even binds to itself. Take a close look at that ball washer scrubby thingy. See how the golf ball is acting like an antigen and is bound by IgA on all sides? It's these IgA immune complexes that deposit in certain locations throughout the body, leading to the characteristic set of signs and symptoms. Complementary, of course. A little reminder that complement gets activated as well, and in many cases, C3 deposits alongside IgA in the walls of small vessels. In the skin, IgA deposits trigger a small vessel vasculitis that manifests as ecchymoses, petechiae, and palpable purpura, usually symmetrical and in gravity-dependent areas of the body, like the legs and buttocks. Arthritis and arthralgias are common as well. The arthritis is usually transient, oligoarticular, only in a few joints, in other words, and is non-deforming, so don't expect any chronic damage. And as he kneels on that golf tee, keep in mind that the large joints of the lower extremities are most commonly affected, like the ankles, feet, and knees. IgA complexes hit the GI tract as well, where they accumulate in the small vessels of the submucosa, causing hemorrhage and edema. About 1/2 of patients will experience abdominal pain that's usually intermittent, colicky, and self-limited. GI bleeding is common as well. The bleeding I'm talking about, though, is microscopic and is detected with a fecal occult blood test, which involves putting a stool sample on a card that changes color in the presence of heme. That's a positive test. Kind of like that golf scorecard he's got there. Not sure if that's actual human feces on that thing, but let's just say he's definitely in the positive on this round. Serious GI complications occur more rarely and include hemorrhage and ischemia. Also, you see that fancy high-tech telescoping golf club? An area of edema and hemorrhage can act as a lead point for intussusception, presenting as extreme abdominal pain as the intestine folds in on itself like a telescope. All right, so far we've got rash, arthralgias, and abdominal pain. To finish off the classic tetrad of Henoch-Schönlein, we need renal disease. IgA immune complexes accumulate in the mesangium of the glomerulus. IgA immune complexes accumulate in the mesangium of the glomerulus, resulting in a nephritic syndrome similar to IgA nephropathy. All the details of IgA nephropathy can be found in our nephritic wall of China sketch. In this scene, just remember that Henoch-Schönlein nephritis usually presents with an isolated hematuria, sometimes with a mild proteinuria. Adults generally have an increased risk of progressive renal disease, consisting of hypertension, nephrotic syndrome, or even all-out renal failure. Again, check out the nephritic Great Wall sketch for a more in-depth discussion. Since biopsy is a little invasive, it's usually reserved for patients with atypical presentations or severe acute kidney injury. Diagnosis of Henoch-Schönlein purpura is most often based on the patient's clinical presentation. Since the condition is self-limited and symptoms resolve as the immune complexes are cleared from the body, treatment is supportive, and the vast majority of patients recover fully with no permanent complications. Let's continue the theme of immune complex-mediated vasculitis with our next hazard on the course. Cryoglobulinemia. Cryoglobulinemia is also a type 3 hypersensitivity reaction, mediated by immune complex deposition, in other words. Kinda like how all those golf balls have deposited in the bottom of the water there. The pathogenesis of cryoglobulinemia vasculitis involves cryoglobulins, which are proteins that are soluble only at warm temperatures, above 37 degrees that is, but precipitate when body temps drop below 37, such as with exposure to super cold temperatures, or even cold-ish temperatures in the extremities like the fingers. Cryoglobulins can be composed of virtually any combination of immunoglobulins, IgG, IgM, IgA, you name it, aggregated together in big clumps. The most common form, mixed cryoglobulinemia, is caused by IgM antibodies directed against the Fc region of IgG, illustrated by this special golf ball retriever contraption. Oh, wait, antibodies to the Fc portion of IgG? That sounds exactly like rheumatoid factor. You know, that thing that floats around in the serum of patients with rheumatoid arthritis. That said, they don't actually cause inflammatory arthritis, likely because they're clumped up in big, well, clumps. Instead, these immune complexes deposit in small vessels throughout the body, causing a wide range of symptoms. Mixed cryoglobulinemia is most commonly seen in middle-aged women, and the most common disease associated with it is hepatitis C infection. In fact, over 50% of patients with cryoglobulinemia also have Hep C. So we've brought back in our Hep C hippo. Hey kids, did you know that hippos are actually considered one of the deadliest animals in Africa? Immediately charging at anything that it perceives as a threat and killing at least 3,000 people each year? So, you know, let's just say there aren't just golf balls at the bottom of that water hazard. Besides Hep C, other conditions associated with cryoglobulinemia in general include multiple myeloma, myeloproliferative diseases, and autoimmune connective tissue disorders, such as lupus. The deposition of cryoglobulins causes a vasculitis syndrome, resulting in the usual stuff: constitutional symptoms, arthralgias, myalgias, and palpable purpura. And keeping with the theme here, IgM precipitates in the glomerulus to cause glomerulonephritis. Well, it's about time to head back to the clubhouse. Let's finish up our discussion of vasculitis with our final small vessel vasculitis, Goodpasture syndrome. Goodpasture syndrome is also known as antiglomerular basement membrane antibody disease, which is, just exactly what it is, for once. Goodpasture syndrome is a type 2 hypersensitivity reaction that leads to the development of autoantibodies directed against type 4 collagen in the basement membrane of glomeruli. Our recurring shark symbol represents collagen, and that flag for hole 4 is there to remind you that these antibodies are attaching to type 4 collagen specifically. See that immunoglobulin fence outlining the putting green? On histology, you can actually see the IgGs lining up along the basement membrane of the glomerulus. This is called a linear pattern of immunofluorescence. Complement also gets activated. resulting in C3 deposition. So let's throw in some complimentary drinks. On the house. I'd like to take this time to thank our sponsors. Crescent Sports. Don't just do it. Do it until you pee blood. The classic presentation of Goodpasture syndrome includes crescentic glomerulonephritis, which leads to a rapid deterioration of renal function and nephritic syndrome. Check out our nephritic wall of China sketch for all the ins and outs, mostly outs, really, of nephritic syndrome. Now, it's not just the kidney you need to worry about. These autoantibodies also cross-react with type 4 collagen in the pulmonary capillaries, leading to shortness of breath and hemoptysis. A lung biopsy, if performed, will show focal necrosis of alveolar walls and intraalveolar hemorrhages on histology. Treatment of Goodpasture syndrome is a little different from the other vasculitides, only because the nature of presentation tends to be more severe than the others. Plasmapheresis is the first line of treatment, in order to remove all the circulating anti-GBM antibodies from circulation. Once that's done and the patient is stabilized, immunosuppressant medications such as corticosteroids, cyclophosphamide, and rituximab are used to suppress further production of autoantibodies.